So let us continue this Barrett's esophagus. So in the last video, I spoke about the definition. I spoke about the pathogenesis. Right. In this session, I'll be discussing about you have the Barrett's esophagus has been you have divided actually. You got a classification. What exactly the classification? You have got something known as Prague's classification, the CM, and you have something known as segments, a short segments Barrett's esophagus and a long segment Barrett's esophagus. So let us understand what is it trying to tell us. What do you mean by short segment Barrett's esophagus and the long segment Barrett's esophagus? So what happens here is, say example, this is a esophagus. Okay, this is a esophagus. This is a stomach, and if you observe carefully here, and this is the layer where you have this is a squamous epithelium. This is the columnar epithelium. Okay. Now, if the metaplasia, remember that if the metaplasia is more than 3 centimeters, right? If it is more than 3 centimeters, you call that as long segment Barrett's esophagus. And if the metaplasia is less than 3 centimeters, we call that as short segment Barrett's esophagus. That's a two important point, right? That's the two important points which we need to understand. And we should also understand you have got something known as a circumferential, that is in Prague's classification of CM. So what is it trying to tell us is, now you have got a C. What do you mean by C? C is nothing but it is a circumferential, right? And what is M? M is nothing but it is an metaplasia. Okay, it is the maximum extent of metaplasia. So if you look into this is a section where this is a stomach here, this is a esophagus. Now if you observe carefully, the circumference, right, the circumference extent of a metaplasia is 2 centimeters. Okay, 2 centimeters. And if the maximum extent of metaplasia, if you take the section or junction from the gastroesophageal junction, the maximum extent of metaplasia is 5 centimeters. Okay, 5 centimeters. So in this Prague's classification, okay, in this Prague's classification, we call this as C2M5. What is C2M5? The circumferential extent of a metaplasia is 2 centimeters, and the maximum extent of metaplasia is 5 centimeters. So this is the GE junction, like gastroesophageal junction. This is a circumferential extension. This is a circumferential extension. This is the maximum extent of a metaplasia. So these are the two important points which we need to understand. Now, the other important points here is, now a person has a GERD, okay, gastroesophageal reflux disease. 10% of the GERD patients, they have the complications of Barrett's esophagus. And who has a person has a Barrett's esophagus, they have a 40-fold risk of adenocarcinoma. Remember that they have 40-fold risk of adenocarcinoma, and 1% new cases increases every year. Every year, 1% new cases increases. So that's a basic point which we need to understand. Now, let us understand you have a different grades of Barrett's esophagus. What are the grades here? You have something known as a non-dysplastic Barrett's metaplasia. Good. You have a low grade dysplasia. Okay. High grade dysplasia. Okay. Right. And let us understand. Let us go in detail regarding these patients. Say example, a patient has the patient has, now say example Barrett's. Okay, you took the biopsy. You found this as Barrett's esophagus. And if in the biopsy, when you look into this, the histopathological slide, and if there is no dysplasia, that means the cells which are present in that has got a no differentiation. They are well, or they have got well structure of nucleus, cytoplasm. There is no dysplasia. Okay. Now what happens? In such conditions, when there is no dysplasia in the Barrett's esophagus, we can treat the patient PPA, proton pump inhibitors, and you can also go with the fundoplication. What is fundoplication? Fundoplication, nothing much, it's a wrapping the upper part of the stomach, that is a fundus, around the lower esophagus to reduce the acid content into the esophagus. Now, when do you call the patient for the repeat endoscopy, right? And you call that as for 2 to 3 years 2 to 3 years once. Okay, 2 to 3 years. So 2 to 3 years once you repeat the endoscopy. That's all you need to understand regarding the no dysplasia conditions. Now say example a patient has a low dysplasia. Okay, so that means that there is some changes, some cancerous changes which we need to understand, but the grade is low grade here. Okay, low grade. Now in this low grade, a patient, we're going to use a PPA proton pump inhibitors, and you're going to suggest a fund application. Good. And what you do is we redo the endoscopy. When do you redo the endoscopy? We redo this endoscopy 6 months. Okay. After 6 months, when you do endoscopy, now say example, if a patient has no dysplasia, right, no dysplasia conditions can be a no dysplasia. In such conditions where you're going to screen the patient for 2 to 3 years endoscopy. Now if a patient has still a low dysplasia, low grade dysplasia, if a patient has low grade dysplasia, we need to repeat, we need to call them up, we need to repeat again, look for the 6 months. You're going to repeat it, we're going to give the same proton pump inhibitors, we call for the 6 months, repeat that. And still if you have a low, then you're going to do with an annual endoscopic surveillance. You're going to do every year, you're going to do the endoscopy, okay, to such patients. Now say example if a patient has a high grade dysplasia. Okay, if a patient has a high grade dysplasia, and in this high grade dysplasia, we have a patient which fit for the surgery. When this patient is fit for the surgery, you go with this esophagectomy, right? And now say example if a patient in high grade patients, what you do is you repeat the scan, repeat the endoscopy for 3 months, and still after the 3 months if a patient has a high grade, now what you do is you go for the eradication is must. Okay, you need to eradicate that mass of the tissue, that is through the ablation, right? Ablation. Now, there can be conditions. There can be a condition when you look into the Barrett's esophagus where the patient can have no dysplasia, low dysplasia, high dysplasia, which I've told you 2 to 3 years, 6 months, 3 months. The patient or the slide, the histopathological slide can also show us an adenocarcinoma. When the patient shows it's an adenocarcinoma, you have a treatment esophagectomy. Now, if a patient has this in the mucosa exactly, right, then you have a different methods where you scrape it out, that is endoscopy mucosal resection, right, we'll be discussing. Then we have got what vago, okay, vago sparing esophagectomy, with that we'll be discussing. And you have got something known as EDS, okay, endoscopic submucosal dissection. We'll be discussing that in detail, but timing you need to understand is very important slide. Okay, now the next point which let's cover up here, the non-dysplastic Barrett esophagus, the progression to the esophageal adenocarcinoma where 4 to 6 per thousand patients. Okay, low grade 5 to 8. Okay, a high grade dysplasia, they can go into the esophageal adenocarcinoma for 14 to 15. If you look into the 1,000 patients of high grade dysplasia, 14 to 15 patients they go for the adenocarcinoma, and 1,000 patients in the low grade dysplasia, you find 7 to 8 patients go for the adenocarcinoma. And when you go for the non-dysplastic Barrett metaplasia, when you go with the non-dysplastic Barrett metaplasia, where 4 to 6 patients, 4 to 6 per thousand, 4 to 6 per thousand. That's all you need to understand. Now, let us understand, okay, let us understand the next very important points here. Okay, next important points. Okay, now I've told you when I've discussed about the high grade dysplasia, right? You remember, right? High grade dysplasia. The high grade dysplasia, you have a methods, okay, methods of for treating such patients, and you have got something as endoscopic resection, and you have got ablative method, and you have surgery. Now, under this endoscopic resection, you have got something known as endoscopic mucosal resection, and you have got something known as endoscopic submucosal dissection, and you have stepwise radical endoscopic resection. So let us understand how this endoscopic resection helps the patient who are in high grade dysplasia. The first point is endoscopic mucosal resection. What happens in the endoscopic resection patients? In here, now if you look into this, this is a mass. Okay, if you look at this is a cancer conditions. Okay, you have a less than 1.5 centimeters, you have n mass, you have more than 1.5 centimeters, it is a piecemeal resection, and it's also written that single or multiple times. Now what actually happens in this condition is, now see, this is a mucosa, right? This is a submucosa, right? You have an os musculus propria further. Now this is what, this is the cancerous conditions which is present in the, where exactly it is present in the mucosa. Okay, it is present in the mucosa. What exactly mucosa is? Mucosa is epithelium, lamina propria, right? Lamina propria, muscularis mucosa. Okay, now this cancer is present at this, where exactly present at the mucosa aspect, mucosa. Now what I do is I start injecting. There's something known as 1:20,000 ratio of adrenaline with NaCl. Now what I do is I can also inject hydroxy methyl cellulose. I can also inject methylene. Okay, methylene. Now what actually happens here is, whenever I inject the 1:20,000 ratio of adrenal with norcelin, now it bulges up, right? It bulges up. Now once the moment it bulges, the endoscopic resection with the help of a cap. Okay, what to do is the cap, it sucks the tumor out, and it cuts. So that's all the basic points which you need to understand in the endoscopic mucus resection, where it sucks and cut technique. Now what happens here is, we have got something known as multi-band technique. Now what happens in the multi-band technique is where this is a pseudo polyp. Okay, this is the polyp, and we use a band. Okay, we use a band for the resection, and 6 resections may be needed. That means remember that the injection in the multi-band technique can be, it can be, you can inject or you may not inject. It has got, okay, fine, you may or may not. Okay, so that's all the multi-band technique, where it leads, you have got something known as, it's a band, it's gonna band it. Okay, band. Okay, band is used here. Now the next important point which we need to understand, you have got something known as stepwise radical endoscopic resection. It is a stepwise radical endoscopic resection. It is seen in the large lesions. Okay, it is seen in the large lesions. Now what happens, what is the disadvantage of these large lesions? The disadvantage is bleeding perforation is seen. Bleeding and perforation is seen in the stepwise radical endoscopic resection. Now let us understand the next mechanism, that is ablation. What happens in this ablation